Kiran sir, can we start the recording, please?
Yes.
Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is treatment failure in children, and the speaker is Dr. Kalpana Datta. Dr. Kalpana Datta, ma'am, is the Program Director of the Pediatric Center of Excellence in HIV Care, that is pCoE, and the Professor and HOD, Department of Pediatrics at the Medical College Hospital, Kolkata. She is also the in charge of the adolescent clinic at MCH, as well as a trainer, national trainer for malnutrition, pediatric HIV, early child development, and the National Tuberculosis Elimination Program. She has authored numerous papers published in both international and national journals. We welcome you, ma'am, for today's session and request you to start the session.
So thank you, Dr. Sheta, for your nice, kind words and introductions. Good afternoon, everyone. Where are the slides? Am I audible?
Yes, ma'am.
Okay. So my topic is treatment failure in children. And this is a common topic, and now we are facing as we are having this children with HIV for a long time. They are on treatment, and also there are many issues we have to address while dealing with the treatment failure in children, because the drugs are limited, the options are limited, formulations are limited, availability is limited. So we have to be very cautious while choosing the drug, in case of, especially in case of the children or the naive HIV children and the first line treatment. And then, of course, the monitoring is very important, crucial part for preventing the treatment failure, because there are lots of issues which can cause treatment failure, may be preventable, in especially in pediatric age group. So by the end of this session, the follow-up monitoring will be doing how we will follow up and monitor the child after ART initiation. Is very important, because if you miss the monitoring, skill monitoring on the protocols, we can miss the preventable cause of failure. Definition and identification treatment failure in children. And the second line ART regime, what will be, of course, if in a few rare exception, if we have a third line, with what will be the third line regime for this children. See, HIV treatment in children as a critical to suppress viral replication, improve immune function, reduce morbidity and mortality. ART is the cornerstone of the HIV treatment, but it is not only the cornerstone HIV treatment, especially in pediatric patients. There are lots of things we should be taken care along with the ART, like nutrition, vaccination, monitoring, growth and development, and all has its own importance. However, treatment failure can occur, and that we have to identify early, we have to address the cause of treatment failure, and we have to give the alternative treatment if required, the second line or third line treatment. So what are the causes of treatment failure as such? Adherence issue. This is the most important issue what we see in day-to-day practice, especially in Center of Excellence. That is the adherence issues, and that may be the very form of adherence issues, and there may be various reasons for the adherence issues. Non-adherence to ART is a major factor. Children may have difficulties with adherence due to taste, pill burden, lack of understanding, and lots of issues. I'll be discussing the adherence issues mainly. Drug resistance, again, HIV can develop mutation that confer resistance to the drug being used, especially if adherence is very poor and if the virus is not fully suppressed. And though the study, we are on the study mode, but there's no protocol for seeing the drug resistance as such in the NACO guideline. But in the study mode, we are doing this and yet to get the results, what is the percentage and the prevalence of drug resistance in children with HIV. In pharmacokinetics, again, it's a very important difference in drug absorption, metabolism, excretion. Children can lead to suboptimal drug levels. Babies suffering from diarrhea can have a decreased absorption, other disease, or some drug interactions, like we know some drugs should not be given with some ARTs. Someone right there is written no voice. Please, Sheta, look into it.
Yes, ma'am.
Difference in drug absorption, metabolism, excretion, and interaction with the other drugs. Like very often the children are prescribed iron preparation, calcium preparations, and other antibiotics, and other the antacids and all, and that may have a interaction with the, especially in dolutegravir. So this is also can hamper the absorption and the efficacy of the drug. Co-infection, that's again important factor, and the malnutrition. If you weigh the malnutrition in HIV, there are two poles of the same type of manifestation. The malnutrition is also affects all the systems, cells, tissues, body functions as it is HIV does. Similarly, the malnutrition can cause severe immunosuppression as the HIV. So it is a competitive malnutrition, and so malnutrition, due to malnutrition, we say NAIDS, like nutritionally acquired immunodeficiency syndrome, and HIV, you said AIDS, acquired immunodeficiency syndrome. So if there's a co-infection or there is associated severe malnutrition, the scenario might be totally changed, and that should be addressed while managing the children. So parameters to monitor during follow-up after ART initiation is a clinical monitoring. Of course, you have to take their good history, and that you have to learn by a process. It's not mug up. So good clinical history is an art and it's a skill also. Thorough physical examinations. Then you have to do the laboratory monitoring. So depending on what are the laboratory monitoring, what are the basis of doing, ARV related toxicity. So what are the drugs you are giving, and that drugs can cause some toxicity, that to be looked into. Intercurrent illness, if you get some features or either in the clinical feature or examination part. Of course, as I said, drug interaction, what are the drugs the child is getting? Because whenever the child goes to some pediatrician and there's nothing to do, like in a viral fever and all, they give some vitamins and calcium and all, as they are not going to give any antibiotic. So they give some drug, and they don't know even when the child is getting ART. So then we get drug and drug interactions and other metabolic abnormalities that should be investigated as appropriate. And of course, we have to see the clinical status, similarly the immunological status and the viral status. For immunological status, you have to see the CD4 testings. And viral load monitoring should be done as per protocol. So clinical monitoring, that's a very important aspect in pediatrics. Just a minute, please. Sorry for the interruption. Clinical monitoring and follow-up schedule for children living with HIV are the growth and development. That's a very important aspect. Growth. So each and every visit you have to see the weight. And you see the previous weight, not only to see the weight and just write it on the green book, your duty is not finished. You see the previous weight, or it is better to plot in a graph. The graph is there in the white card. I never see someone who plots the graph in the white card. That should be fulfilled. So plot on the white graph. And if you plot in the graph, no, even the parents can see growth is better or it is halting or is deteriorating by seeing the shape of the graph. And the shape of the graph can be observed even by the illiterate parents also. So very important to see the weight and put on the graph. Then of course, any malnutrition, any nutritional deficiencies, any micronutrition deficiencies, any vitamin deficiencies, you have to look into. It won't take much time, only 5 minutes. You see from head to toe. Just see the eyes, mouth, body, skin, you'll get lots of features. So in every visit, you always monitor growth and nutrition. Then developmental progress. Again, developmental progress is just a common question you must ask. Whether the child is growing as part of the other kids. Everyone have some other either own kid or in the family members or in the neighbors and all. So you can just compare them whether he's growing well with as par with the other kids or something different. And if at a time there's a scale also in your white card, you can plot. It's very easy to plot. Just see the age, what is the age of the child in a month, and there is a month wise and there is a developmental scale is there. We just put a vertical line on that month, and whatever the bar, which is the left side of the bar, as more than 75%, those milestones should have been achieved. So you can draw it and you can see it and compare with the child. So developmental progress is very important because sometimes it happens, baby is improving with the clinical improvement, there is a virological improvement, but baby is having encephalopathy. Baby is having stroke. Why? It is whether it is because of the disease or the drug or other concomitant infection or other etiology you should look for. So that is very important to know the developmental progress. Then of course, for screening for tuberculosis, that is also very important. We know there's some difference in screening in kids and adolescents and adult, and adolescents are as you do in adult, but in below 5 years, always look for the history of contact is very important. And of course, the not gaining weight. Baby is not losing weight, but not gaining weight is also important, because this is a phase of constant growth. And this growth starts from the day of conception, when mother conceives, till maturation. So there will be constant growth of the body. So if baby is not gaining weight, that is also one of the feature of something wrong, or some infection is there, and that is the one of the screening positive in case of tuberculosis. And of course, others are not gaining weight, or losing weight, fever, unexplained fever, unexplained cough, as in guidelines says any duration, but of course you apply your clinical acumen, because in viral infection in rainy season there will be lots of viral infection, baby will have fever. So all cases we are not going to screen for tuberculosis. Your clinical acumen will be applied for that. It is not viral infection, then you can go for that. So these are the history of contact in the family members, or in the neighbors, or to whom he is having daily contact, maybe a teacher, maybe the cook, maybe the maid, maybe the driver, to whom the child is having daily contact for a long period. That is also to be taken in consideration of the screening. Then clinical monitoring of and for opportunistic infection, again, is very important. If you won't search, you will miss. And you will miss, not only miss the diagnosis, you also miss the child also, because that may be the killer of the for the children. It may not be the HIV which is killing the child, it may be the secondary disease which are there. So you have to look for the opportunistic infection. We know the common one are the GI infections and respiratory infections. And of course, then other infections quite obvious, if it's the neuro infection or muscle, joint pain and all, then you can get. And the treatment adherence. So after taking thorough history and proper examination, each and every visit, then you go for the treatment adherence. What are the drugs baby is taking? Not only the ART, any other drugs like ATT, like pyridoxine, like vitamin D, like other multivitamins, B complex. So all those drugs, whether baby is what are the drug they are getting? They might be confusing with the other drug of the ART. So always separate these drugs. This is ART. This should be taken this type of this way, and these are the drugs which can be taken this way. So each and every drug you have to take in account while taking the treatment adherence. Calculate the ARV dose as per weight. This is again very important criteria to note in each every visit at the center, because there's a huge fluctuation of weight in children. If a child is having a diarrhea for 2 weeks, baby will lose weight. Again, there's a proper nutrition given, baby will gain weight. So there will be change in weight, and I always calculate the change in weight on every visit, and always try to see the dose was given according to the particular weight or not. If it is some drug is given last month, a baby came after 2 months, and baby has gained weight for 2 kg. So the dose might change. It is in a borderline phase, it might change. So always see whether baby was given appropriate dose, weight appropriate doses are given or not. In each visit, this is mandatory to check for the proper monitoring of the child. Okay. So please note, every visit check body weight for infants, children. Drug doses need to be changed, as I said already. Now monitor children's adherence. That's very important. This is the main attraction of the children living with HIV. So you have to give maximum time for adherence counseling and checking the adherence. If you ask the adherence, they will say yes. The child is taking regularly medicine. I can see mother will say, yeah, baby has taken the medicine in my presence. But when you interrogate, you will find the baby has taken the medicine but vomited. So if baby has vomited within 15 to 20 minutes, there is no absorption at all. You have to repeat the dose. Sometimes while swallowing, he might keep in the mouth, and after a few minutes, he will throw it out. The caregiver did not notice to swallow the tablet. Sometimes there may be a bitter taste. She didn't take and said, no, I have already taken. I'll take, Mama, you go. I'll take the medicine. So there are lots of issues. Even I have seen recently, I have seen 2 cases where adolescent, and one is the young adult. It's not an adolescent also, she's a young adult. So she was near about 24 to 30 years. And she was not taking medicine regularly. To my staffs complained me, madam, this is the girl, you look at the child, girl. She is not taking, we are fed up of this. We are tired of counseling this lady. You come and discuss. So I talked to her, why you are not taking medicine? You are doing harm to yourself. You are quite old. You are quite grown up. Why are you not taking? She said, one of the staff member behaved badly with me. I'm like, if she behaved badly, could have complained to me. You're doing harm to your own health. So I'm assure you, no one going to behave badly with you. Take the medicine, and you promise it. Then she promised, okay, I'll take the medicine. Another adolescent girl came to just few a week back, and again my counselor said, "Madam, I'm fed up. She's not taking any medications, and she was near 16. She's 16 or 17 years old, not taking any medication, very irregular." Then I called her. Why did you do this? She didn't say anything. Then I said, look, I'm wearing a specs. If I want to wear specs, I won't be able to see the thing. If we want to live in this world, we have to be healthy. There's no point living with a sickness and a bedridden and all. So if I can't see, I can't do my work. If someone is a hypertensive, if she doesn't take the antihypertensive, maybe that person might have a cerebral hemorrhage, a stroke, and he might die in some time. So for my health, I am taking. So when you are having HIV, you have to take the ART. If you want to be slim, you're just because adolescents don't need all those the advices, preaches, and long-term benefits. They are not going to listen to you. Adolescents are totally different from the adults and from the pediatrics. So you have to behave according to the adolescent's need. So I said, she is very slim and all. So I said, you want to be slim like this, or you want to be obese or not? No, I want to be slim like this. Okay, if you want to be slim like that, you have to be healthy. And if you want to be healthy, you have to take the medicine. If you want to be beautiful, you have to take the medicine. So again, you have to counsel accordingly. And after counseling for half an hour, before going back to her own place, she told me, Madam, if I take the medicine, I'll be cured. So if you see the half an hour, whatever I discussed with her, she didn't realize. After half an hour, she said, if I take the medicine, I'll be cured. I'm like, do you need the cure or you want to be healthy? Like me, I'm having a refraction error. It won't be cured in my life if I have to wear my specs. But I can jolly well see clearly if I see the specs. My hypertension is not going to be cured. If I take the antihypertensive drug, I'll be normal, normotensive, and be as good as normal the person who is not having hypertension. Similarly, if you take the drug, you'll be as good as normal person who are not having HIV. Then she promised me, and since then she is taking the medicine regularly. So in that way, you have to check the adherence. You have to behave with the according to the need of the child or adolescents. And of course, there are a few things given in the guideline, like you count the pill count. These are all protocols, but pill count does not do anything. They will throw it, they will hide it, and you will see the count is normal according to the adherence. Though one pill count is one of the method to see, but always other points to be taken in account. So report by the caregivers. Again, you ask the caregivers. If you counsel the mother, suppose you counsel the mother, or mother at home, she is going for other work, for she may be working somewhere, she gave the charge to her older daughter. What will happen? She will counsel her older daughter, and the quality will be decreased. So if you ask who will take the responsibility to feed this tablet to your kid, if she says my elder daughter, you will ask the mother to bring the elder daughter, and you will counsel the daughter. So counseling will be good quality. It should not be deteriorating. If you forward the counseling from one person to two person, it will be gradually quality will be decreased. So you directly counsel that person who will be responsible for taking the tablets for the kids. Then, of course, refill the boxes again. You have to see the boxes. You have to count it with it. You have to ask them how to make reminders, and you can give some tricks to remind daily reminders. So that may be anyway, checking pills, charts, calendar, diaries, any alarm clock, or any can you can make any things in the calendar, or you can count the pages. You can write a note, whatever you like to remember, the way you want to remember. You make your own choice, or the center who are working in the center, they might give some clues to make it how to make it. Remember daily morning or evening, whenever you take the medicine, how to remember that I have to take the medicine, because sometimes we may forget, and they will say, no, daily I am taking the medicine. Whenever taking the medicine, if suppose he says at 8 a.m. I am taking the medicine. When is the school, she might say it's 10:30. Okay, then the holidays, what you'll do? You'll get up at the morning. Oh, today's Sunday. I'm not going to get up so early. I'll get up at 10 or 9. Then what will happen? The tablets. So these things you have to take in the holidays, in the vacations, or we're going out in the sports day, or there's when there is change in daily routine. How will you manage to take the tablet at the fixed time? That should be taken care of while counseling the parents and caregivers along with the kids. Regular child's visit to the center, again, I have to check it. Sometimes they don't come usually because they are going to school, tuition, extracurricular activities, exam. Lots of issues are there for the kids. So they don't come usually. Parents come. They'll say, no, my kid going to some vacation, mama's place, or auntie's place, aunt's place. I have come to collect the medicine. But you have to see the child because there is a change and you have to make them understand what is the importance of to bring the child to the center, because you have to clinically examine the child. Is there malnutrition? They are not able to identify the features of malnutrition. So you have to identify the features of malnutrition. You have to see the weight and age, weight appropriate medicines given or not, you have to check. So if they don't bring the child, this thing will be ignored. So always make them aware that is the very important to bring the child regularly. Others to other co-medication, as I already said. So other medication, what are the drugs like the Septram, whether he's cotrimoxazole taking, he might be taking the antitubercular drugs, or sometimes might be taking some antibiotics, some supplements, B complex, calcium very commonly prescribed. So whether they are taking it regularly or at what interval and at what time, that should be also taken care of while counseling about the adherence. So let's exercise one, please. So I request all the ART staffs, please answer this question. Very important. An 8-year-old girl on ALD with weight 24 kg. So 8 years, 24 is okay. The weight is okay. Patient, ALD as come for pill pickup. Father asked the doctor, why has CD4 has fallen and viral load report is 10,000 copies per ml. As per father, her grandmother is giving her the pills regularly. See, there are very important points here. Before going to the further down, I just here highlight first, whenever there is the 8 years, you see the weight. Okay. What are the drugs? ALD. Who came? Father. Have you consulted the father? Then, as father said, the grandmother is giving the table. Have you consulted the grandmother? Oh, my grandmother is too old to come. Then how can you counsel the grandmother? So you can do the Zoom meeting also, but it is better to bring the other caregivers who can take the counseling. And CD4 has fallen and viral load report is high. Why? My father is very much worried. If my baby is taking regularly medicine, I'm watching personally. My mother is watching. Grandma was watching. Even when the baby is not responding. On inquiring, child revealed that she was taking 2.5 tablets of AM. Pediatric twice daily and one tab DTG 50 once daily. So what is wrong here? For the 24 kg, it should be 3 tablets twice daily. Inadequate dose, so the dose is underdosing. So if this is underdosing, then there will be chances of failure, chances of resistance, chances of opportunity infection will be there. So the correct dose of AL will be 3 tablets twice daily. So that is the importance of taking care of the weight and checking that dose. Inadequate dose of AL pediatric for the weight band was the reason for high viral load report. So this is not in a failure because the dose was low. So as I already said, what steps should be taken to avoid this situation? Whenever you change the dose, you must counsel the parents and along with the kids also. Because it was not properly counseled, it has been increased from 2.5 to 3 tablets when baby was crossed 20 kg. So they were giving 2.5 tablets per that, and now he is still there. So these things to be taken care of about the dose and schedule. So to step to avoid this, every week check body weight. This repeatedly has been asked. Yes, very good. Weight record. Thank you. Doctor from Mandi, Hemant Kumar is written. Yes, that's very important. You check the weight, and is my honest request. Before checking the weight, please check the weighing scale. You check the weighing machine also. Sometimes the indicators they want, and that will give 1 kg extra. If some disease will be negative and then before 0, then it will give the false low weight. And if it's more than a positive side, it will be false positive weight. So always checks before checking the weight, you check the weighing scale. whether it is properly zero is indicated as zero or not. And then ask the child on the sit on or wait, stand on the weighing scale without clothes and minimum clothes. Again, it happens, Okay, they came in summer. With the only one sando Genji, and you took the weight one light pant and light shirt there, and you weigh the child and baby is suppose at 20 kg, and again at October it is supposed 22 kg, but suddenly in December, because there is a sudden change of weather in some places, in December they come with the monkey cap, the thick socks, and the big sweater, half sweater inside the shirt, then full shirt, then full sweater, and you're taking the weight, it became 24 kg or 25 kg because of the weight of the clothes. So you should take care of that. You should be aware of that. You should above minimum clothes. Take the minimum clothes on the body while taking the weight. Otherwise, there will be change in weight, and you can change. Falsely will think that baby has gained weight or lost weight, and we modify the dose. So before doing all those, this is the prerequisite for taking the weight of a child. So first check the weighing scale, check the baby's clothings, and ask them to stand over the machine. When he will stand still, then notice the weight and then note it down. So these are things to be done while taking the weight. Drug dose have to be modified according to the change in body. That you should not forget, because we're taking the weight. Taking the weight, then you see the tablets. It is no need to remember all those things. How much tablet for what is the weight? You keep your that drug dosing sheet in front of you and see. Don't unnecessarily bother your brain. So no need to remember this. You just see the drug table, and according to you just alter the dose. At every visit, counselor should speak to the child also to confirm the dose of medicine being given. That's very important. Not only the kids, but also the parents, caregivers who are there in the family. Otherwise, we might miss. We have seen many varieties of poor adherence. Recently, I saw one adolescent girl. She said, I'm taking the medicine regularly, daily, and the 1,000 persistent more than 1,000 viral load. It is a put, sometimes it's 1,800, sometimes 1,500, and 1,200. Then I personally asked her, what is the problem? You are missing tablet. Otherwise, it is going to down your viral load. Let me know. Please tell me. She said, no, that is, I'm feeling gale mein atak jata hai. I cannot swallow just a big tablet. She is an adolescent, but she is having some problem. I said that, listen, anatomically, the lumen is able to swallow. So it is your psychological feeling that you are not able to swallow. So you will be able to swallow it. She said, no, I'm feeling I whenever take medication, I feel suffocation and all. That is all psychological. I said, okay, after taking medicine, you do one thing. Either you take one mashed potato with all salt and all prepared on chokha types of potato and swallow it. Or take one lump of ripe banana and swallow it. Your tablet will be pushed down. She said, okay. And that way, baby was improved on our adherence. So there were different issues. You have to check the individual issues and have to give the solutions for the individual issues. Medical officer should reinforce the dosage change to caregiver and the child. Yeah, this is not only the job of counselor, to whom the child may come in contact during the center, all are having a same responsibility to take care of that, the doses and caregiver. And if you, the medical officer, the last person who is the best person to counsel, so they should take the responsibility whether the counselor is given that the child understood or the caregivers have got the message. So you have to recheck it. Yeah, how many tablets will going to take? What the counselor said, let me know. So if she will tell, you will realize the baby or the caregivers has understood the counseling. Pharmacists should also reinforce the doses, prefer write it on the bottle with the marker. That's a very best thing to do. If you can mark 3, if it's 3 tablets, you can mark 2 or something they can do so that there's a compliance can be better. Okay. So adherence and monitoring in childhood and children. Pediatric ARV options are limited. We don't have a liberty or having lots of drugs, preparations, or the availability. So we have to be very cautious about prescribing, adherence, and monitoring so that they are not going to go in a failure. Poor adherence plays a significant role in the emergence of drug resistance and subsequent treatment failure. So for the last 5 to 10 minutes, I am emphasizing on the adherence and adherence only, because that is the most common issue in pediatrics for the drug failure and of course subsequent drug resistance. Ensure the checking for treatment adherence, clinical monitoring, testing in every visit. There might be some situations where you might get if there is a viral suppression is there, but there's no immunological improvement. There's a immunological failure. Then you have to think with other causes which can cause immunosuppression, like concomitant severe malnutrition, tuberculosis infections, any others like chickenpox and varicella, or pertussis. These all can cause the CD4 suppression for the timing, and that will give the immunological failure, though there is no virological failure. So then discordant condition where the virologically baby is okay, but clinically failure, don't think baby is an immunological failure. So baby is not responding, baby is a failure. No, the other causes are immunological failure. Similarly, the baby is having a viral, normal viral load, immunological, but clinical failure. The always think other features which are responsible for clinical failure, maybe the other concomitant diseases. Barriers to adherence should be assessed and addressed regularly. There are lots of issues regarding the barriers. Maybe a mother is sick, baby is orphaned by either both parents, a single parent, baby is taken care of the grandparents, or sometimes they are in the orphanage or home, or sometimes they are taken care by the aunts, just only for the keeping at home or for the food purposes. They are not so much responsible. Lots of issues are there for the adherence in the children. So you have to identify each barriers and you have to overcome that barriers by their individualized way. Then of course monitoring, you should not forget the monitoring, because suppose baby became anemic, baby is on ALD, not on JDBD, because on JDBD we are very much cautious to see the hemoglobin. So baby is on ALD and baby is gradually becoming anemic. It didn't bother. Oh, baby is not getting JDBD, I am not interested. No. What is the cause of bleeding? Why this anemia? If you won't be able to understand, you won't be able to diagnose, refer it to the center where it can be evaluated. See the cause, because gradually anemia, baby will lethargic, sick, then baby will stop taking ART, and then we artificially creating ART failure. Not because of the ART, but because of anemia, because of sickness, because of the opportunity medication, baby is not able to take medication. So this is very important to see each and every visit. Of course, other drugs, according to the drugs you are giving, so you'll see what are the, according to the protocol. I'm not going to read all the monitoring protocols because it is given in your table. You have it with you, and you're doing, of course, you are doing the long time. You are aware of that, but should not forget. You should not forget to see the lab, because we have seen sometimes we do get the sachet referral. 6 months back, the hemoglobin was done, and they have sent the patient to the center. So what center will do? We cannot do the immediately hemoglobin all the time. So it should be taken care of, whether the hemoglobin is done, blood urea is done, and some drug to be given which can cause kidney damage of the blood urea, serum creatinine, urine analysis, creatinine. And of course, when you are giving the PI, sometimes the lipid profiles quite high. You might give some lipid lowering agents, though it's not properly used, but you have to give some time. Random blood sugar. If planning for the PI and all, of course, we didn't get any hyperglycemia, but of course, we do get hyperglycemia in the adults. So we should always look for the blood sugar, baseline blood sugar before starting PI and DTG. And CD4 percentage and count. This is very important. When to see whether it properly counted or not, properly calculated the percentage and are machine oriented. You see it. And the age appropriate percentage, or sometimes what happens till 5 years you are seeing the percentage, at 6 years you are seeing the absolute count. So you will be in confusion if baby is having low CD4, but it is because of the, now it is an absolute value. Previously we are looking at the percentage value. So this thing to be taken care of. And of course, in adolescent girl, if there's a history of a sexual exposure, always go for the pregnancy testing, and at the baseline you are going to do screening for TB. In each and every visit, you are going to do this screening. And of course, that plasma viral load at the per guideline at the 6 months and 12 months, and after 18 initiation, then if baby is okay, a normal CD4, a normal viral load, and you can go for the yearly basis. Now, the monitoring children is the routine visit. Everything I have to monitor, as I've already discussed about the growth and nutrition, physical thorough history, physical examination, developmental assessment, any concomitant opportunistic infection or TB or malnutrition. What I see personally, maximum time the malnutrition is ignored, because malnutrition is also can cause the immunosuppression. It will delay the recovery. It can incite lots of opportunistic infections. So always take care of malnutrition, and please do some advice about the nutritional part. Confirm clinical staging and check the lab reports. Check adherence to ART, calculate the ART dose, review concomitant medication, as I already said, discuss finding with the caregivers, always discuss with the caregiver. Okay, this is why. If baby has low weight, discuss why there's a low weight. Then if you take the history, you'll say, oh, 2 weeks back, baby had a severe diarrhea, it was treated in local hospital. So if you get this type of history, if you take the thorough proper history. And always discuss with caregivers what are the options to overcome that problem. Provide referral as needed. Advise, guide, reinforce, support adheres to ART nutrition. Of course, the vaccination we shouldn't forget, because that the vaccine preventable disease can be taken care of if we give the proper vaccinations. And if possible, to provide referral as needed. What I was talking?
Vaccination, ma'am.
Yeah, actually, some phone has come. Review the content. Okay, this is the finding the caregiver, whatever the finding you are getting, provide the referral as needed. Advise and guide, reinforce, support adherence to ART, nutrition, when to seek medical care and medication side effects. That's very important. Side effects, again, one of the important aspect to look into. So you have to I mean, that part is that you have to gain that knowledge. You have to acquire that knowledge. What are the drugs which can cause what side effects? So side effects are like the anemia, lipid profiles, bone mass density, renal failure, kidney disease, liver disease. All those should be taken care of. Oh, I was talking about the vaccine also. So government NIS, National Immunization Schedule, all the vaccines are given free of cost from the center, even though we do get the patients we are incompletely immunized or totally unimmunized. So it's our duty to send them to the center for vaccination. If he has come to your center and baby has not taken any vaccination, you ask someone to accompany to your nearest vaccination center, get the vaccination done. So otherwise, they are not going to get. Of course, before giving the vaccinations, the protocols to be followed, like the immunosuppression, what is the stage of CD4 percentage, what is the CD4 values, whether any opportunity infection is there or not, whether severe acute malnutrition is there or not, whether there's a live vaccines are contraindicated at this particular age or not. These two things to be taken care of. And if you are at all in any confusion, you take the advice from your referral centers and pediatric center of excellence. And especially, I can say all of the 7 pediatric center of excellence are very much proactive. You can contact with any pediatric center of excellence for any advice. Everyone is ready to give you advice. So please don't hesitate and call and communicate with your centers. And of course, if you don't say the follow-up visit, next visit, then again problem. And while next visit, always take care of the date. That day might be you asked to come in that after 1 month, that day he is having some viva. That day he is might have some exam. That day he is having some competition. So always take care of. आपको कुछ है तो नहीं इसमें, कहीं जाना तो नहीं है, कुछ करना तो नहीं है. Is it okay for you? So before giving the date, always take care of the kids' opinion also, kids' problem also, kids' activities also. Don't ask only the caregivers, because that time caregiver will say, oh, my baby is having an exam, so I didn't bring him. I came for taking medications. So you'll miss the weight opportunity to measure the CD, any OI or weight and all. So these things taken care of while giving the next visit. So after 6 months after starting ART, it's very important. May suffer of new events like opportunistic infections. Opportunistic infections like severe opportunistic infection, fungal infections, zero-base pneumonia, they are for the depending on the different immunological status. But common opportunistic like infection like gastroenteritis, diarrhea. In the time of dengue, there may be dengue, there may be if baby is not vaccinated for typhoid fever, baby might have a typhoid fever. But these are other common disease. Hepatitis A, because it is not in the national immunization schedule. Hep B is given, but Hep A vaccination not given. So there may be a hepatitis A infection, and everything, all the clinical feature will be altered. The response to ART will be altered with these opportunistic infections. These things to be taken care of. If any symptoms are there, whether it is iris or it is an opportunistic infection, you have to see. For that, you have to take the detailed history, examination, and sit for count. ART-related adverse effects, again, if some baby is having a diarrhea for after taking ART, baby will stop taking AL without telling anyone. So always take your tolerating. Are you liking the tablet? Do you have any problem with the taking these medications? So these things to be very closely with the kids you have to deal with. New behavior and lifestyle pattern being set. So depending upon the tablets, timing, the confidentiality, and the all those things, so taking medications, and you have to change some your schedule, because all the kids are having some schedule or some timetable. They're busy all the time, 24 hours 10. So see their timetable, see their activities, see their schooling. I always say, when is their schooling time? Always ask that. It's a morning time or 10 a.m. and 11 a.m. or the afternoon session or morning session, because some schools having two sessions, and then in summer it will be early morning session, then other time it is a day session. So how to manage the tablet, how to take the medication, all those things to be taken care of. Then of course the rapid gain in weight, especially the child was malnourished earlier. So if there's a rapid gain in weight, that is not acceptable. Because why there is rapid gain in weight? There will be a proper gain in weight, not a rapid sudden jump. There may be some heart failure, there may be edema, there may be some other problem, or there may be drug toxicity. So there should be a gradual gain in weight according to the treatment protocol and of the malnourished children. Chances of misunderstanding doctor shopping alternative treatment. If you don't give the time, you don't counsel according to the individualized counseling, modified counseling according to the child's need, they'll go on, they won't come second time. Especially in the adolescents, they are very much watchful. They are watching your behavior, how the doctor is looking at me, how the doctor is behaving with me, how he's sitting, how he's wearing, how he's dealing with me and all. So if he won't like your attitude, the behavior and the practice, they will start stop coming into your center, and they will देखा जाएगा मेरे को क्या होगा बाद में देखा जाए, मैं अभी नहीं जाने वाला हूँ ये आर्टिस्ट सेंटर में, वहां के डॉक्टर मुझे पसंद नहीं, वहां के वो आदमी हमको पसंद नहीं है, because they are least bothered about their future, their life and all in adolescence. So you have to make them very friendly, comfortable. We have a lots of sessions for adolescents separately. I'm not going in detail. This thing, otherwise doctor shopping, they will go on changing the center. Many times we see, हमको सेंटर से दवा नहीं लेना है, हमको आपके सेंटर से दवा लेना है. आप कितने अच्छे से बात करती हैं, कोई और तो बात नहीं करता है. They don't give time. आप कितना टाइम दी. So these things matters while dealing with the patient. Most mortality in children occurs before within few months of starting ART, or else after treatment failure or discontinuation. Of course, there may be because sometimes what happens, there's a virological suppression, there's a gradually virological suppression, but there's no immunological suppression because of the other concomitant disease or causes, and that may lead to a death. And there may be side effects, and if there's a irregular treatment, poor then that may lead to treatment failure, and ultimately they will be sick and they will stop taking medication, and so there will be discontinuation of the drugs. So again, another important part after adherence is the disclosure. So disclosure is a complex process and very, very sensitive process. You can imagine a child when he will know that this disease is because of their parents, from their parents. How hatred it is for them. He will hate their parents. Sometimes we have seen an adolescent, he ran away with the family. He was out of the knowledge from the family, no contact with the family for many, many months because he was in depression. So these things will be taken care of by disclosing, improve the adherence to medications, reduce psychological distress, increase likelihood of appropriate disclosure to others. Disclosure in pediatrics, the ease appropriate disclosure will be there. And the timing of disclosure to a child cannot be universal because the maturity level varies from individual to individual. So it's a continuous process. One day you came and asked the child to sit with you with the parents and you know you are having HIV and this. No. gradual. You are having some disease, you have to take medications, you have some viral disease in one sitting, you can say one disease, like I'm having this, I'm taking medication, you are having this, you are taking this medication. In that we have to acclimatize the child. Then the next session, you will see you have some viral disease. Then another session, you will disclose the HIV. Then another session will disclose the other, how the HIV acquired and what is the importance of taking ART and how it will be improved, how you maintain your health and daily activities as good as normal one. This should be the continuous process. You cannot achieve at the same sitting. Disclosure should also follow a planned process with the level of disclosure over time, as I said. Caregivers and all children, as it 5 years or more, should start being prepared for the disclosure. So after 5 years, partial disclosure, 6 to 9 years, means you are having some disease, you have to take the medicine. So that can be done by one-to-one discussion on sitting, or you can play some comics on the cartoon play in the TV if you have a TV, or can show the storybook where the person is sick and took the medicine, became healthy, and fight with the that Godzilla, fight with that bad person, and he fought and he owned the things. Who took the medicine? Who didn't took the medicine? He was fallen sick and he was not able to fight with that bad person. So in that we can give the disclosures and seeing these all those pictorial representations of the diseased person with taking medications with a healthy outcome, diseased person not taking medication with a poor outcome. So that will give a good result. And of course, that when they are mature enough, they are able to understand the things, then you give the full disclosures. So now transition to TTG-based treatment is already in the process. Everyone is giving it because we have got it this OM from NACO on 2023. This is 2024. So it is in the process. So this is the algorithm. I'm not going in detail because 18 children, we know avacabate based treatment, and age appropriate dolutegravir can be given 10 milligram per body weight dolutegravir. It's not per body weight dolutegravir, it is age appropriate dolutegravir. So dose is scheduled divided according to the age weight group. You see the chart, and according to the chart, you give the dolutegravir. If the child is living with HIV with less than 20 kg and less than 6 months ART, then I feel there's already virally suppressed, then you have to change the switch of the drug with the dolutegravir. This is already done, I think, because it came in the last year, and still with the loss of patients, new patients that started on the dolutegravir basis, and who were on the other drugs like PI and basis. We have seen the viral load. If suppressed, then you treat it. So switch over to, if virally not suppressed, then the second line with the dolutegravir based treatment. If suppressed, then only dolutegravir to be changed. So this is the protocol came in the last year only. It is there in the practice. So this is a quiz time. I think now all the attendants are get ready and please answer. So a situation, suppose the patient is an AL-LPVR and viral load is 200 copies. What will be the regime after transition in the dolutegravir based regime? Anyone? The quiz time, please interact. It will be good to hear from you people. Okay, so I got some chat message. Let's see what is there in the chat. Okay. So what will be the answer? 200 copies means virally suppressed. Will go for the single drug change. Only dolutegravir. AL plus dolutegravir DTG. Again, ZL LPVR 800 copies. So only LPVR will be changed to DTG based regime. So ZL and DTG. Now see the AL LPVR viral load 1200 copies means virally not suppressed as per definition or guideline, NACO guideline. Repeat viral load after enhanced counseling. When we say the virological failure or go for the second line, when after enhanced counseling, enhanced adherence counseling, more than 95% adherence will be there for 3 consecutive months. And if thereafter the viral is not suppressed, then you also go for the second line. But here it is, see, it has become enhanced adherence counseling 600 copies. So what we'll do? Again, AL Only one drug will be changed, the DTG-based tablet will be there. Now the second one, ZLLBBR, viral load 1800 copies, repeat viral after TND. So again, same. So this is our the brain stimulating game. You see, ALLPBR, viral load 1200 copies, means not in viral failure. Repeat viral load after 2600 copies, still above high. So what will happen? So you have to switch over the second. Now it is a second line, because first line failure, there are lots of issues. I received a lots of questions while doing the review meeting in our state about the switch and transition. There's lots of confusion. So it's very important to see when we say the first line failure or second line failure, or just the one drug is changed from like lopinavir to PI2 or dolutegravir based regime. So as this is a failure, after enhanced adherence council to 2600 still high, we'll go for the, because our option is ZLD. Whenever you are giving the ZLD, you see the hemoglobin. If it's more than 9 gram person, you can add ZLD. If it's below 9 gram person, then you just do the continue the AL and place the LP or D the dolutegravir and check the cause of anemia. What is the, because you are giving ALPBR. So AL is not responsible for anemia. That may be due to nutrition. That may be the other disease. So treat the anemia. Look for the causes. Maybe worm infestation. So treat the anemia according to the cause, and then check, and then you can switch over to the second line. Again, if the patient is ZLLPBR, viral load 1800 copies, repeat viral load after enhanced is 10,000. So it is again a high, the same guideline to be followed. Define a stable child. So when you say the child is stable, especially in 2 to 10 years age, because the stable adolescent and adults are different guideline. So at least receiving below 2 years, we are not going to say stable child, because there is a very much chances of fluctuation of the stable child's definition below 2 years. And there may be there will be lots of fluctuation in the weight, the growth, and lots of things are confounding factors are there below 2 years. So the stable child's definition from above 2 years to 10 years. Receiving ART for at least 6 months. Viral load is suppressed, means by guideline less than 1000 copies per ml. Should be on the same regime with no dose or formulation change for at least 3 months. So baby in the stable and taking regularly same drug with the virally suppressed conditions. Should not have any active illness, medical condition that frequently requires further management. Not only the ART related, maybe ART not related, maybe some other infections, maybe malnutrition, maybe concomitant diseases. Treatment adherence more than 95% in each of the last 3 months. So baby is taking medications. Sometimes baby is 90% taking medication, 90% even viral supplement. No, it is more than 95% adherence should be there. Wait for, as I said already, if there should not be any malnutrition, more than -2 SD. That means no moderate malnutrition also. If less than -2 USD, we say moderate malnutrition. If it is less than -3 USD, we say the severe malnutrition. So even the baby is not having moderate malnutrition or the stunting for that disease, you will say the stable child. About 10 years, the guideline as good as the adult. On ART for 6 months, no adverse effect on ART that require regular monitoring, no current illness, opportunistic infection, medical condition that requires management or regular monitoring. Suppressed viral load, by definition, less than 10,000 copies per ml. In the absence of viral load monitoring, we don't have, sometimes machine is there, not that there, the things are not there. You know, in the program, there may be some issues for not doing viral load. And then you see the rising CD4 is there or not, or falling CD4, which have to take into account. Rising CD4 from or the CD4 cell counts more than 200 cells per cubic millimeter, and there is more than 95% consecutively over last 3 months, should be taken as a stable child. I told many things about the adolescents. Now adolescent friendly health service is there in medical colleges and different colleges in all over India. So you have to have a adolescent friendly ART services also. Adolescent means 10 to 19 years. Experience rapid physical, cognitive, psychological growth, not only physical, cognitive, but social also, social growth. So you have to how to deal with the society, how to deal with the peers, and all those issues are there. There's a rapid changes. This affects how they feel, think, make decisions, and of course interact with the world. Adolescents with HIV face considerable challenges and have unique needs and vulnerabilities. Adolescents living with HIV are often less likely to start ART because they're less likely to be sick. They're harboring the HIV, but they're not sick. So they say, why should I take medicine? I'm quite well. Long back, I was diagnosed with HIV. Still, I'm not having any disease. So, no, HIV, humko kuch nahi kar sakta. The attitude is like this. So I am not going to have anything with the HIV. I'm okay. I'm doing gym. I'm taking medicine. I'm taking protein powder. All those things. No. So there were lack of adherence, suboptimal adherence. So you have to counsel the adolescents. Very cool, sensitive issue. So more likely to get lost to follow up. More likely to have an unsuppressed viral load. And the issues may be many because of non-adherence, loss to follow up, and unsuppressed viral load. Not only the issues lies in the adolescent, maybe issues lies in the ART center, maybe issues lies in the staffs of the ART center. Lots of issues are there that to be addressed. Adolescent HIV care may have two entry points. So how will you get the HIV positive adolescents, reactive adolescents? Either they are vertically transmitted, now transition from pediatric to adolescent, or though acquire male to male sex is very common in adolescent sexual abuse. Of course, the thalassemia childs, the other children who are getting regular blood transfusion or injection or some IV drug users. So those acquired the infection in adolescent age group, those and the transition from the pediatric age group. HIV testing and treatment studies should be adolescent friendly and include mental health support also, because I'm not going in detail in mental health because time is not there, only 5 minutes is there. But a bit, in case of adolescent, what happens? The frontal lobe matures later than the limbic system. So what does the limbic system do? It is the system for emotion. So they're very emotional. But the appropriate judgment, concrete thinking, abstract thinking will develop later at the age of 24 years. So frontal lobe matures at the age of 24. So they're mentally very imbalanced. You'll see lots of suicidal attempts, lots of suicide, accidents, drug abuse start at the time of adolescence. So that things to be taken care of. The counselor should give some importance to the mental health. It is critical that ART staff practice non-judgmental adolescent-friendly care and support. Of course, you should not judge. Oh, why have you done this? Why have you come like that? It's your fault. You have done this. This should not be uttered. You have to be very friendly, non-judgmental, and I have to empathize their problem. Adherence and retention barriers of adolescents are different from pediatric group and that of the adults, of course. Extended adolescent-specific service hours to be provided. Adolescents experience rapid physical, cognitive, psychosocial growth. You have to give the information regarding that also. So physical growth, that means the age-appropriate nutrition. Cognitive, so you have to take the mental issues. Psychosocial growth and the sexual growth. So age-appropriate sexual education is very important. If you don't give the sex education, don't give the information regarding sex, they will get it. They will get it the information from different wrong sites. So it is better to get it from the proper site, from your site, not from the other websites. So they'll get all the wrong messages and the false belief will be there. Linkages with the scheme to the developed life skills. There are lots of programs, government programs, non-government organizations doing lots of programs for the life skills and mental health and adolescent issues. You have to link them with that issue organizations. Access to the health services, including sexual and reproductive health services, that is RKSK, Rashtriya Kishore Swasthya Karyakaram, is there. You have to make them access to those services also. Approaches such as peer mentoring, support groups engaging adolescent volunteers, peer navigation, focus on caregivers should be considered. So you have to select peers, or you have to select the peer leaders. You can counsel them, the group counseling. You can do both group in counseling. You can do both heterogeneous group counseling, means both female child and female adolescent and male adolescent combined together, like vaccination, nutrition, mental health issues. And you can do the homogeneous counseling, means only the boys, only the girls, and that way. And again with the parents, without parents. And so different type of counseling should be done in adolescence. So there is existing networks are there, lots of youth clubs, there are driven clubs, national service schemes, national cadet corporations, Red Cross Society, lots of groups are there. They're working, constantly they are working on the orphanages, homeless children, street children. So you have to make them available those resources, all the schemes so that they are easily get that services. Then establish the linkage with the Swadhar scheme for the women who are deprived, and then they can be having this scheme can go for the government of India is there. Ujjala schemes there and rehabilitation centers, particularly for adolescents, KPs are required. Key boxes. Linkage with the existing program, as I said, Rashtriya Kishor Swasthya Karyakram, Kishor Shakti Yojana, Rashtriya Yuva Sashakti Karyakram are there already existing in our country, and they should get availed of those services. Now there's some question.
Yes. Give us a minute, ma'am. We'll run the e-poll.
Biological failure in children is defined as 2 consecutive age.
I'll read out the question, ma'am. Participants are requested to please attempt the e-poll. The question is, virological failure in children is defined as 2 consecutive HIV-1 plasma viral load values of more than or equal to 1,000 copies per ml, with which of the following criteria? Mark all that apply. After 6 months of ART initiation, after giving 3 sessions of step-up adherence counseling, adherence in each of the last 3 months was more than 90%, or all of the above. You can click on the answer on the screen. Requesting all the participants to please attempt the e-poll.
Should you go for the next session, next slide?
Yes, ma'am. Kiran sir, we can end the e-poll. Thank you, everyone.
Now the most important part is identifying the treatment failure. But still, we are getting some wrong answers. I think we should.
Ma'am, we'll display the correct answers at the end after post-test.
Yes, yes. So next slide, please. So identifying the treatment failure. So definition of treatment failure, it may be a virological failure, maybe immunological failure, maybe clinical failure, maybe a discordant failure, like there's a biological failure, no immunological failure. There's a immunological failure, no clinical failure. Or there's a biological failure, there's an immunological failure, but no viral failure. So there are lots of permission combination situation may arise. How will you define? I'm not going in detail because of the lack of time. You know, virological failure means after 3 months of enhanced adhering of more than 95% consecutively. At least they have taken the ART for at least 6 months. Even after that, if there's a virus more than 1,000 copies, it is the virological failure. Immunological failure, again, there is a different criteria for different age group. Children between 12 to 35 months is more than percent of CD4 below 15%. In 36-59, it is less than 10%. And children aged 5 years and above, as per the adult criteria. Fall of CD4 pre-therapy level of 50% fall, or persistent CD4 level below 100. Newer clinical failure, when there is a stage 3 or 4 conditions, progressive neurodevelopmental deterioration, of course, this is also stage 3. And severe not only growth failure, severe growth failure is the clinical failure features. So how do you improve that? To prevent failure, a minimum 3 sessions are recommended for step-up adherence counseling. All counseling sessions are to be taken preferably by the same counselor, so there's a rapport building. That is very important. The first thing is to do the rapport building. And if you go and changing the counselor, there'll be no rapport with the patients. Both caregivers and the child should be counseled together and individually in all the sessions. Counselor needs to review all the barriers that lead to poor adherence and provide customized counseling. As we discussed in the session previously, the poor adherence, cause of poor adherence and all that to be addressed. A customized adherence plan should be developed with the involvement of both the caregiver and the child. Ensure weight documentation in white card. So it's very important to fill the white card. And green book on each visit and check if the correct dose is given as per the weight cut. CSC to be involved for counseling, supporting the caregiver, the child to help them achieve required adherence. Group counseling as already should be taken by tailoring support for the children, different age groups of PRT centers, and it will be very encouraging if all the children are same age group, all the adults are the same age group, and they will interact with each other, they will exchange their views, they will exchange their opinions and all, and that will make them interesting. To allay the fear of side effects of ARB, assurance should be given to the caregiver, the child, that will be taken care of all the artists under the reported in time. So, like as I said, there's one fear that she is not going to swallow. She is not able to swallow the tablet. She was quite 16 years old, and she said, "I'm not going to able to swallow the tablet." So I asked other adolescents, and how did you find this? They said, "No, look the Lilith Angoli." In that way, can be that can be overcome also. So peer leaders will be there, peer consultation will be there to overcome the barriers also. Assessment of mental health of the caregiver and the child, and timely referral for appropriate management should be done. So how to improve the counseling strategy to educate and counsel them? Since first session, first slide, I'm talking about the counseling and counseling. It's very important to do the counseling regarding health, about the disease, about the ERT, about the adherence, what it will be, the importance of adherence, all those things. Very fast, they have to start, and it is continued throughout their visit. Regular counseling sessions. Support system, the peer support group, as I said, peer support group and community support group are there existing. That should be availed by the adolescents or the parents or caregivers. You have to make them channel. So you have to make it a linkage so that they will get the services from them. Simplifying the regimens. So sometimes we see, like in the last session, Sasif also we have seen, because she's not able to taking so much medication, so much tablets, pill burden and all. So if there is some modification can be done, or you ask them to increase the weight by giving the diet chart, and also that you can give the one drug like TLD, if it's more than 30 kg, more than 10 years, the TLD, the fixed dose go in the single tablet. If a baby is getting, suppose three tablets, and after a few kg, he or she will be eligible for TLD. You make them realize that if you take the proper nutrition, proper diet, and the high rich calorie and protein, and after a few months you will be able to take it. So they will see some rays of hope, and so then they will be more obedient to your advice. Once daily regime is always preferable. Reminders and that's very important. Reminders, incentives, not bribing. Don't bribe child. Others you will create other problems. Temper tantrum and all those things will happen, and the mental problem will be there. Reminders are important. You can use alarm, phone calls, text messages, prompt medications, taking all those things. Any clues you can give, any other ways of reminder you can use. Incentives. Provide incentive to or rewards for the consistent adherence. And I like to say, don't give the incentives in the form of artificial food, junk foods. It's our habit. Whenever something, I would give a chocolate, give a cake. No, give coloring books, give the story books, give the famous people's biography books. Whatever the way you can give, you give the incentive, and ask the parents to give it, not the the cake and chocolates and the other shake and all. Addressing psychosocial factors. So again, I'm reminding mental health support is very important to take care of, especially in adolescent. Family and caregiver support is very important for counseling, and this should be always taken. You have to maintain all the points that you have covered the points in the while counseling. So important consideration before diagnosing treatment failure is very important. You will, once you stamp the treatment failure, oh, everyone, so baby is in treatment failure, to change the drug. No. What is the importance of treatment failure? Why there's a treatment failure? Search the cause. And in the 90% cases in pediatrics, at least we have seen it is because of the adherence, poor adherence, not because of the drug resistance. Child should have received the current ART for at least 6 months. Adherence to therapy should be more than 95%. Acute or opportunity infection should have been treated properly. Immune reconstitution inflammation should not be confused with the treatment failure, and that should be addressed separately. Malnutrition may mimic failure, and that should be taken care of. Adverse drug reaction may also mimic clinical treatment failure. Of course, so we have to be aware of that. Review whether ARV doses as per the current weight or not, as we have seen in the first case that the underdosing was given. So it's very important to see the appropriate drug doses before going to the treatment failure. Another case, diagnosed was HIV on 15th, and it is a case of transitional care from the pediatric adolescent because vertical transmission. At 1 year, baby was started ALLPBO, and LFU for 2 years, actually 2 years, so 2017, Monata, I don't know, this 2019 is written. Reason ART and 2019 after 2 years means 4 years gap. LB again, excuse me. Weight was 9.5 kg, so a bit low, malnourished. Doses, the AL given 1.5 tablet twice daily, LPBR the 40 pellets again, 3 caps twice daily. Viral load was quite high, 43,000, and weight is now weight is 11 kg increased. 3 sessions of state up of other advanced counseling were given. Repeat viral load were 41,908. Now, do you diagnose treatment failure in this child, and how do you manage? So you should write in the chat box. So by definition, is it a treatment failure? So what are the things we'll take care of? First, you see the child is, consider the weight, see the weight appropriate dose was given, whether baby has taken proper drug for at least 6 months with the good adherence more than 95% for at least 6 months taken the drug and the intense adherence counseling to be done, and where they maintain the adherence for more than 95% for consecutive 3 months. Thereafter, if this viral load is quite high, you can say it's a failure. So clinical assessment for acute opportunistic infection, IRIs, adverse drug reactions, malnutrition to be ruled out, as I said before, taking failure. Check whether dose is appropriate for the weight or not. So general LPB here, if there's a weight less than 20 kg, patient is DTG, weight general LPB here will change to ALD. No problem. But if previously exposed to abacavir, suppose if you have come, then when the abacavir is given because of the toxicity or the side effect, it's a change to ZLLP. You not give the, then what will you do? Will ZLD, you have to continue the ZLD, like that means only one drug have changed, but you have to be very cautious. Till then, baby will be 3, 4, 5, 6 years, 20 kg, make them nutritional care and other OI treatment and other, so they will increase to 30 and can switch over to TLD. Between 20 and 30 kg, ZLLP or ALD. Again, same, if there's exposure to avacavir or any other side effects to avacavir, you can go to the continue the ZLD under close monitoring. And of course, we have to try to increase the weight so that you can switch out the adult drug. And sometimes we have to give the modified drug. ALLPBR, again, if the hemoglobin more than 9 gram person, again, DTG, ZLD. If less than 9, again, ALD to continue, but always take care of anemia, treat the anemia, and when it's more than 9, switch over to ZLD. If more than in between 20 to 30 kg, of course, same guideline, more than 9 grams, ZLD, less than 9 grams, continue ALD, treat anemia, as well as more than 9, switch over to ZLD. So, patient is on ZLE, F of is based NNRTR. So, weight less than 20 kg, ALD, ZLD to ALD. So, all until else baby is more than 10 kg, 10 or more or 30 or more, we cannot change it. ZLD to LD till it becomes more than 30 kg and more than 10 years, it is TLD. And if it's an ALD, again, same formula, I'm not going to repeat. Failing regime, the first line of fail. So, patient on ALD, let's continue the same thing. But if it's an adolescent who is having more than 10 years and more than 30 already on TLD, because now the first line of treatment is the TLD. So suppose they fail, what will you go for? Then the chances of you have to switch over to JDL and atageneral conditions. Access to multiple NRT. This is very important. Second line ART option for children exposed to multiple NRT. If tenofovir and avacavir based regime and the third drug is PI, then you have to AJT and D40. CD4 count was not suggestive of immunological failure at the time of substitution from AJT to TDF, then it was not a failure. So it is because of some other issues, substitution done because of the other issues. So to weight less than 20 kg, hemoglobin is okay. Then what can you do? ZL DTG. But hemoglobin is not okay. You cannot give jadobin, then you have to give the ALD because we don't have any other options in less than 20 kg. Tenofovir is not as appropriate dose is available. It's only there for about 30 kg. So there are no options. You can continue ALD until we can switch over to ZLD after treating the anemia. And if it weight between 20 to 30 kg, you can, of course, so you can wait. And when it is more than 10 and 30, you can switch over to DTG-LPV, recycled non-energetic based NRTA backbone. So DTG-LPV can be given in between 20 to 30 kg. It's yet to, there's no guideline which can be used, but in third line we can use, and double dose DTG yet to have a guideline for failure cases, especially in pediatrics. So now current failing first line failure with a history of multiple NRT exposure. CD4 count was suggestive of immunological failure at the time of substitution from AZT to abacavir or tenofovir. So you have changed from abacavir tenofovir to AZT. So what will you do? Weight less than 20 kg, DTG LPVR. So you can give the less than 20 kg DTG LPVR, and 20 to 30 kg DTG LPVR along with the recycled non-AZT based NRT only have to add. That is only after 20 kg. So another question for the, I think, Polly.
Yeah, ma'am, you can continue. I'll run the post-test till then. Kiran sir, can we have the second poll?
Okay. So I'll go the first
Yeah,
side.
please continue, ma'am.
Okay, actually, the initial second line ART and ART children with HIV coefficient are not going in detail because time is already gone. So I'll say whether patient is on ART, you started ATD. If rifampicin based, DTG to be doubled. If patient is on DTG based treatment, you have to double. Or if he's already.
Ma'am, you can continue.
Yes, slide is gone. Let me check. Okay. Yes. If he's already on ATT, when baby is already on antiviral drug, then you are giving DTG based drug. Then if patient lopinavir, ritonavir based drug, you have to super boost, means previously 4:1. Excuse me. Now it will be ratio will be 1:1. And if DTG is taken, then you have to give the additional dose of DTG 12 hours apart. That to be emphasized. If baby is already taking the DTG at 6 p.m., you have to take one DTG at 6 a.m. And of course, as I already said in the very beginning, you should not give any calcium iron preparation, so take care. Previously, baby was taking DTG at evening, so baby was taking calcium and iron in the morning. Now we added one DTG in the morning. So that gap, 6 hours gap should be there. 2 hours before and 6 hours after the DTG, there should be any intake of calcium iron preparations. If already on rifampicin, contaminant, you are adding ATD, antitubercular drug, patient is on ART, adding antidote, you have to modify the ART. So if lopinavir based drug, you have to give the 1:1 ratio. If it is a DTG based drug, you have to give extra DTG. 2 weeks after that, you have to keep in mind, 2 weeks after this stoppage of rifampicin, that should be kept in mind. So you have to counsel. You can imagine one fist of tablets will be there. So pill burden is quite high. Hence, should be counsel about the antiviral drugs and second line ARTs. If patients not started second line ART immediately, then can do first line till switch over to second line. ART should be reverted 2 weeks after the stopping of rifampicin based antiviral treatment. So if antiviral treatment given, then again you have to stop the extra dose of dolutegravir. Adherence monitoring on second line is very important because we don't have luxury to the many third line drugs and pediatrics. So we have to be very cautious, very strict about the drugs and adherence in second line. And you have to emphasize that to the caregivers also. So they should also realize we are handicapping at a certain time. So poor adherence to ART often results in the development of resistance to ARV drugs, and the most important cause of treatment failure in children. We don't have a good enough third line drug in our hand. Hence, intensive adherence monitoring of child and second line ART should be done. Infant and children are dependent on adults at time for timely and correct doses of ART. So you have to counsel the caregivers. That's what is importance of giving the drugs at particular time and particular dose for the children. Child must be directly observed to swallow. As I already said, sometimes they keep in the mouth. As soon as the parents or caregiver look on the other side, they spit it out or throw it out. Poor adherence can also be due to caregivers issues discussed previously. Hence, the caregiver must be assessed for issues. Counsel accountability. You must keep the second caregiver ready. If mother is sick and all. Use all adherence tools to support the child and caregiver, like flip charts, coloring ART, calendars, peel box, favorite TV series, cartoon series. Disclose the child as appropriate. Monitoring follow-up again, as in do the first line, similarly in the second line also, body weight, clinical monitoring, proper history, proper examinations, growth monitoring, nutritional monitoring, development, staging, treatment, whatever you are doing in the first line, same thing, more enthusiastically you have to do in the second line also. So last case, I think Mr. K was initiated JDD in 2016, CD4 300. Regime was ALE due to anemia, hemoglobin fallen below 8.8. 7 months after ATM session. CD4 count time substitute was 750. So it's good. Age is not given. Okay. So 15 September 20, his viral load is quite high. Repeat viral load 2000. So what will you do? Hemoglobin 40, hemoglobin is now good, age is 13. So what will the second line treatment? Is it JDD? Is it failure? Second line, eligible for second line? Anyone? Are you getting the answers on the chat box?
No, ma'am. Participants are requested to please put their answers in the chat box.
This person, because we are doing daily. You are doing more than us. We, as a pediatrician, comes and see the patient, but you are in the ERT center, you are dealing 100 of patients daily. So you know all those things. Just practice yourself so that there will be no mistake. That's all. So answer is yes. 28,000, and after we have counseling, it is 22,000. So it should be JLD. But you know, there are some studies, so it can be sent to SASIP, and SASIP can see if it's a dramatic fall. You see, to 28,000 to after adherence 2,000. Just now we had in the last yesterday, 2 days back also, I had a patient, a SASIP patient from other center. So only to 1,500 viral load. And it's drastically decreased from the previous value. So it is decreasing trend. You can increase the adherence a bit further and continue and ask them to do the viral load after 3 months. You can see it is in a viral suppression. So that should be taken care of, especially in the center of excellence for this type of patients. Because the 28,000 to become 2,000, I think it is possible to make it below 1,000. For an 8-year-old male child, body weight 23 kg, currently on DTGL, second line, following third line. Which of the following third line we have prepared? Yeah, this is again you should do.
Ma'am, you can continue with the next slide.
Sure.
We'll keep the poll running. You can close it from your end, ma'am.
Yeah. So, child with poor treatment adherence, a major opportunistic infection to be ruled out. If there's treatment adherence is there, then improve the adherence. If opportunistic infection is there, treat the opportunistic infection. Then you consider the failure. If it's not there, then refer to the SASIP and pCASIP and all. And there will see the viral load. What is the tradition of decreasing trend? What is the decreasing trend? What is the increasing trend of CD4? What is the clinical? Everything will be taken in account while giving the third line advice. So second line ERT failure and third line ERT, maybe due to poor adherence, using modified adult formulation can be given because we don't have any pediatric formulations for third line. Switching to second line ERT, late switching to second line ERT. All children with the second line ERT need to undergo viral load testing every 6 months, as the guideline says in an adult also. So see, less than 6 years, less than 10 kg, we don't have anything. Filling second line is AL, LPBR or JDL LPBR. Continue the second line, because you know the third line, we don't have any third line modification and all. SL, I don't think stability is available in our program. Is it available, Dr. Mr. Sita?
Dr. Ravi, sir?
SL, stability. I don't think it's available in our center. We don't have SL also. So
I'll check, ma'am.
So age more than 6 years, after 10 years, and body weight 20 to 30 kg, then there's some options you can give as an adult. This is as above 20 kg, mind it. Above 6 years, above 20 kg, you can give DTG double dose with lopinavir with existing NRT backbone. That cannot be given below 6 years. So still we don't have the guideline that. So third line can be given. Is more than, of course, there's more than 10 years, 10 and 30 kg as an adult. We can go for the double dose of dolutegravir. Means again double dose means again 12 hours apart. LPBR to be added and existing NRT backbone to be maintained. So laboratory monitoring in patients on third line, of course, it depends on the drug dependent investigation will be there, because you have to know what are the side effects of which drug. Accordingly, you have to monitor the child. So this is my last session of the last slide of the session. Following the structured follow-up protocol is critical to optimal management of children initiated ART. Adverse events related to ART, though usually transit and minor, are the most important variable for optimal adherence. So it's always see the adherence issues. Early and correct identification of treatment failure is vital in children for appropriately selecting the second line ART regime. Regular viral testing is essential for the early identification of treatment failure. So we have seen sometimes the baby has referred to SASIP after 1 hour, 1 year. The 2 viral failure was there before they had. So please mind it in your centers also, and who are in my under my centers and all the ART centers. I'm requesting always look for the viral load at regular interval. When there is a protocol says it's a failure, but that means after 3 months of enhanced adherence counseling, more than 90% adherence issue is still viral load high. Please refer in time. Don't delay in referring. Poor adherence plays a significant role in the emergence of drug resistance and subsequent treatment failure in children living with HIV. So thank you. Now we go for the post-test. If there's any questions, I will have to answer.
Yeah, thank you so much, ma'am. Dr. Ravi sir has just answered in the chat box. SLN is not in the program. We don't have SLN.
Yes, not in the program, but it is a guideline and it is given in the by your slides. That's why I asked this question. I know it is not available in our center also. There's no guideline on the SLN based treatment. So as it is, I think this should be removed from the slide. No,
we will make the changes.
okay. So there's.
Thank you so much, ma'am, for facilitating this session. Ma'am, please allow me to share my screen.
Yes, Dr. Ravi's excellence not in the program. Yes, but as in the slide, so we should not talk which is not available because they might ask them who are in the ART center.
Yes, we actually have very rare cases where the people are on this single pill regimen, but not usually no more recommended in the program now.
Okay, yeah.
Thank you so much, ma'am, for facilitating this session.
I'll just take this question, Dr. So, yeah.
So we end the session here?
Yes, ma'am.
Thank you for.
Thank you, ma'am.
Thank you so much, ma'am. That was very wonderful session.
We'll circulate the PPT, and along with that, we'll circulate the answers for the e-poll also. Okay. Thank you, everyone. Thank you for patient listening. We'll conclude the session.
Here, if you look at the question 1, so the question is very clear that virological failure in children is defined as 2 consecutive HIV-1 plasma viral load more than 1,000 copies per ml, and which of the following criteria? Okay. So when you say virological failure, so virological failure is more than 1,000 copies basically, but no. Whether to initially say that it is more than 1,000, then we decide that it's a virological failure. No, we say that the patient has to undergo an enhanced adherence counseling for 3 months, 3 consecutive sessions with more than 95% adherence, and then repeat the viral load test. Even in that case, if the viral load failure is there more than 1,000 copies, then we say the patient is a virological failure condition. And now, as per the revised guidelines, I think we have an NDLS session very recently by Dr. Eshu Agarwal, which says that NAGO has revised the EAC 1 and EAC 2. Suppose EAC 1 may you say that, if compared to the previous viral load, the viral load has been decreasing, but still, the desired effect is not there. Do we need to refer to SASEP? No, again, we do an EAC 2 again.
Yes,
and then see, yeah, EAC 1 and EAC 2 can be repeated. And then if it is again coming up more than 1,000, if the patient is adherent on medicine for last 3 months, more than 95% is there, then we say that the patient is virally failing, then refer to the SASEP for an appropriate decision.
So, yes, that's a nice, your suggestions are very good because we do it in the pCoE, because if you search it, there will be some issues on the adherence.
Yes, exactly.
Adherence issues, maybe the compliance, maybe the tablet, maybe the flavor, maybe the taste, maybe the size, and lots of issues that to be taken care of before telling a stamping as a case of failure.
Yes. So usually, when we get these questions, when they say no, so the patient was adherent and no viral load compared to the baseline viral load has come down now, but it has not reached less than 1,000. Can we refer to SASEP? So there is no need basically because you have given the one counseling of 3 months adherence counseling, and you can see there is a clear cut. No, the viral load is coming down. So you tell the patient to be adherent, maybe retest the patient after the second EAC part of it. Then there is no improvement, then you refer the patient for the
Yes. That's why you have to see the trend of decreasing
trend of the serial
Yeah.
viral load counts that we have to monitor.
How see the
So,
trend?
yes, yes. Yeah, I think,
Thank you so much,
fine.
Dr. Ravi, sir, for the kind guidance.
Thank you, thank you.
Thank you, sir.
Thank you so much,
Thank you,
Dr.
ma'am.
Thank you.
Thank you, everyone. Kiran, sir, we can end the session now.